Hello, good morning, good afternoon, good evening from around the world. I'm John Callum from the University of Pittsburgh, and I'll be chairing this session on hemoabsorption and novel supportive therapy in critical illness. We have two speakers who will be speaking about related topics, and then we'll have a fair amount of time, hopefully, at the end for some discussion. If I can have the first slide. So as I mentioned, I'm Dr. John Kellum from the University of Pittsburgh. We don't need to belabor the rest of this. Next slide. Our first speaker is Dr. Franz Schamais, who's the chief of the Department of Anesthesia and Intensive Care in Baden, in Austria, and the rest of his credentials are there, and I won't belabor them in the interest of time. Next slide. And then our second speaker is Dr. Asam Goyabay-Veya, who will be speaking second, and she is a specialist in inpatient and acute kidney injury in Kazakhstan. And so with that, I'll briefly show you the agenda again. Next slide. And these are some discussion questions we may get to at the end. So if we can start with the first presentation from Professor Schamais, that will be great.
Thank you, Mr. Chairman. Thank you, ladies and gentlemen, for the great opportunity to speak here and to present our data and our experience. First, my disclosures. I've got speaker fees from several companies, and then now a short agenda to structure the presentation. I will tell you from where we come. I will tell you our indications. I will tell you how we do it, and then we show the data we have gathered. Austria is a small country in the middle of Europe. We are in Baden, a little bit south of Vienna, and we have there a very new hospital and a very well-equipped hospital. We have 450 beds and 24 intensive care beds, and there's a mixed intensive care structure headed from the anesthesiologists. We treat a lot of patients. We treat surgery, we treat trauma, we treat SSDI, we treat pancreatitis, some organ failures, obesitas, and last but not least, we treat sepsis. And I do not have you tell the definition of sepsis, but the 4 columns are source control, antibiotics, fluid resuscitation, and vasopressors. And if all this does not function enough, we combine these 4 columns with hemoabsorption therapy very quickly as a adjunct treatment option. When do we make hemoabsorption therapy? Mainly in sepsis, when the patients are very severe ill, when they have a refractory massive vasoplegia and do not respond to vasopressors at all. We make hemoabsorption therapy when there is no improvement despite of adequate treatment and there is a life-threatening condition, but then we make it very, very early. We make hemoabsorption therapy in toxic shock syndrome. We make that with pancreatitis when there is a multi-organ failure, with liver failure. We do it with intoxications for drug removal, and we do it with rhabdomyolysis. But mainly it is, the indication is sepsis. To illustrate this short case that we got 3 months ago, that was a 74-year-old female with a BMI from 45. She had had a hip replacement and the gallstone procedure, and she's got an infection with Enterobacter cloacae. When she entered our unit, she was on norepinephrine with 1.7 micrograms per kilogram per minute, vasopressin with 6 units per hour, dobutamine. She was anuric and she had a severe hypotension. These are the charts of our patient data management system. On the beginning, we had norepinephrine load of 1.7 micrograms per kilogram per minute. We established 3 cartridges, and after 24 to 36 hours, we were down on 0.17 micrograms per kilogram, so showing that this is a very, very potent therapy. And here you can see the impaired renal function. You see the blue lines, that is the cumulative fluid intake on the days, and you see the red bars, that is the cumulative urine output, and you see that this starts on day 3, and it became a really sufficient renal function. How do we do it? We combine CVV HDF with adsorption therapy. We combine a Chevron HA330-2 or 380 with CVV HDF that we make over Prismaflex or over Prismax. That is the newer one from Dextagambro. And the advantages are all staff is familiar with this modality. There are no problems. We may stay on citrate anticoagulation. We need only relatively small central venous lines for dialysis, and we only need a very low blood flow. We combine Chevron HA330 with a regular Hemo filter system. We use prismocitrate in a very low concentration. We have additional substitution fluids. We compensate calcium and magnesium, and we change the adsorbers in an interval around 12 hours. We combine the hemofilter membrane with a surface of 1.55 square meters with a very large adsorber surface with about 60,000 square meters. And in the case of HA380, about 80,000 square meters. We can cover the whole spectrum of molecular weight with hemofiltration, the lower spectrum until about 30,000, and with hemoperfusion from 10,000 to the albumin that lies by about 65,000. This is the model of hemoperfusion. Small molecules are passing the cartridge, and the cartridge is a adsorbent resin in that binds larger and middle molecular weight molecules, and the blood cells are going through. Why do we use HA330-2? Because the resin is very sophisticated, the filling is very sophisticated. It has improved blood compatibility. It has no interactions with anticoagulant. It has a mechanical strength, a more mechanical strength, and it is a double cross-linked resin that is very stable and reduce the risk of particle filling. And the third reason is it binds very potent bilirubin and bile acid, and it helps again against the dysfunction of liver failure that occurs in about 50 to 70% of patients with sepsis. And if the liver is injured, there may be toxin accumulation, there may be bleeding, there may be impaired nutrition, there may be bacterial translocation, and last but not least, organ damage. And the HA330-2 and the 380 are superior to the HA330-1. We have built up a protocol together with a company in Nipro that shows how you can establish such a system and how you can build it up and can fill it. This is together with Gambro, Baxter Gambro machines, but you can use this protocol for Fresenius or Pete Brown too. And now to our data. The first thing that we found is with the use of every cartridge, the platelets drops about 30%. And we had a closer look at our data we made in the last 3.5 years. Quite a lot of hemo perfusion therapy, but for now I only want to focus at the Schaffron group. The Schaffron group was mainly sepsis and septic shock. This group has had after SARS-3 a predicted mortality of 70.5%, and the observed mortality in our group was 28.6%. We measured a lot of inflammation parameters. We measured vasopressors, we measured bilirubin, creatinine, and myoglobin. And I will show you our results. As I told you before, the platelets are dropping very, very quickly. After 3 cartridges, you have lost half of the platelets. Our lowest value was about 12,000. We do not establish an additional system when the platelets are around 20,000, but we didn't have a single relevant bleeding. And if you look at a graph per patient, you see in every patient the platelets are going down. The same it is for norepinephrine. Norepinephrine goes down very, very quickly, and on the after 24 to 36 hours, you have quite a comfortable situation concerning the norepinephrine. You can see this, the highest value was 1.97 microgram per kilogram per minute. And in each patient, the values are going down. The same it is for vasopressin. Vasopressin is reduced about after 48 hours with the Hemo-absorption system. If you look at PCT, PCT goes down. That is no wonder, because PCT is bound to the hemofiltration membrane and to the cartridge. CRP is going down 1 day later. IL-6 is going down very sharply on the first day. And IL-6 may not be a good entry criteria for the therapy, because you have various high IL-6 levels before the therapy is started. So you can get patients with 65,000 IL-6 or with 500 IL-6, and both groups can be very massive vasoplegic. The leukocytes are going down, not so much. Lactate is going down when the shock situation resolves. Myoglobin is going down. You can remove very potent myoglobin in other conditions with this system. Bilirubin is going down. It depends on the value before. If you have a very high value of bilirubin, it comes down very quickly until about 6,000, and then it stops. You can reduce creatinine, but it is no wonder because it is a renal replacement therapy. Our other indications were liver failure, were rhabdomyolysis, and drug intoxications. And we had, like I told you, undesirable effects concerning the thrombocytes, the platelets. But if you stop the therapy, the platelets become going up. And I've said it before, we had no relevant bleeding, even with values about 12,000. And undesirable effects can come with antibiotics and the drug removal of the cartridge. There are several papers that show this for meropenem and for linezolid, and another paper that shows it for quinolones. And the authors said that you have to overcome these situations with giving more doses of the antibiotics and with therapeutic drug monitoring. So to conclude, according to our experience in absorption therapy is a very powerful adjunct treatment in the sepsis. It might have a positive effect on outcome, it might save life, and it might be time dependent. I will stop there. Thank you very much.
Thank you very much, Franz. We'll save questions for the end, and we'll try to maybe tease out some of the points that you made during your presentation, which was very excellent. Thank you. So we're going to move on to our second speaker, Dr. Asam Noige Beiva, who I hope will forgive me for pronouncing her name, and she will discuss further applications of this technology. Please go ahead.
Good day, dear colleagues. I would like to say special thanks to the organizers of ISICEM and Jeffron Company for the opportunity to participate in this webinar. Dear Chairman, dear colleagues, it's a great honor for me to present the preliminary results of our work, experience of clinical application, extracorporeal hemocorrection in treatment of patients with COVID. So here you can see the official statistic of COVID-19 in Kazakhstan on the 6th of September. There are immune response in some COVID-19 patients may lead to severe cytokine release syndrome, with consequent organ damage. Since April this year, FDA temporarily authorized the emergency use of cytokine removal device for the management of cytokine release syndrome in COVID-19 patients. There are a lot of investigations has been starting for evaluation of effectiveness cytokine absorption with different points of treatment start, extracorporeal hemocorrection modality, and indications. The aim of investigation to determine death risks and odds ratio in patients with COVID-19 with cytokine absorption versus conservative therapy. And the second, to evaluate the dynamics of laboratory parameters, procalcitonin, interleukin-6, and CRP during the treatment with cytokine absorption. The characteristics of patient groups. All COVID-19 patients were at ICU. They had a multiple organ failure, subtotal lung injury with acute respiratory distress syndrome, and received CRT due to acute kidney injury. Patients were categorized into two groups according to extracorporeal hemocorrection treatment regimen. The first group received conservative therapy, CRT, and 3 hemo absorption with cytokine absorber HA330. The indication for starting HA was sepsis. The second group received only conservative therapy and CRT. When comparing these groups, statistically, significant differences in age, interleukin-6, and CRP levels can be noted. Hemoabsorption regimen were next. Duration of hemoabsorption was 6 hours. Interval between procedures 12 hours. Blood flow 200 milliliter per hour. Anticoagulation, as anticoagulation, we use heparin and cytokine absorber, HA330 absorber. We insert it to the hemofiltration or hemodiafiltration circuit. Number of procedures was 3. In risk assessments in group of patients, absolute and relative risk, odds ratio, and Fisher exact P were calculated for these two groups. The odds ratio shows that the risk of death is higher in the second group compared with the hemoabsorption group. However, obtained data are not statistically significant for this group. Comparison of these indicators, procalcitonin, interleukin-6, and CRP before and after each hemoabsorption procedure showed a statistically significant decrease in level of procalcitonin and interleukin-6, but the change in CRP levels was not statistically significant. Then we continued to compare groups between each other. So this ISICEM test revealed a statistically significant decrease only in procalcitonin and interleukin after the second hemoabsorption procedures. Changes in CRP also remain statistically insignificant. Conclusion. Patients treated with cytokine absorber and CRT and patients receiving conservative therapy and CRT had comparable death risks, maybe because of small number of patients, and we should continue to make investigation. Therapy with cytokine absorber HA330 shows statistically significant decrease of procalcitonin and interleukin-6 levels in dynamics after the second procedure. So also we have such inflammatory phenotype. Patients are not homogeneous in terms of their inflammatory phenotype and have widely varying levels of cytokines in their blood, not only interleukin-6. Thus, it's necessary to develop acute respiratory distress syndrome risk scale to determine criteria for the earlier start cytokine hemoabsorption in view of the inflammatory phenotype of the patient and explore the wider cytokine profile. It's also necessary to consider the issue of continuous cytokine absorption for the first 24 hours or more, possibly in combination with CRT, since one of the non-renal indications for CRT was an acute respiratory distress syndrome in adults. Also, I want to thank my colleagues for their joint work. There are Dr. Safarova, Vakhrushev, Zhunusov, and Odalova. Thank you for your attention.
Thank you very much, and thank you for staying on time. It gives us some time for discussion, and there's some questions in the Q&A that directly relate to your talk. Ask them about the sort of selection for patients with COVID-19. It looks like the patients that you described all had acute kidney injury and were on CRRT as well. Have you used the therapy in patients prior to renal failure, or are they all patients receiving CRRT?
Thank you for your question, Professor Kellum. Yes, we have such kind of patients, but but we start to use hemabsorption, cytokine absorption for such kind of patients recently, and maybe one or two patients. Also, our clinical protocol doesn't recommend. Doesn't still including cytokine absorption for as a main treatment. That's why we couldn't start and make some basics for starting therapy.
Yeah, thank you. And I think that certainly logistically, it's easier to apply these therapies in patients that are already receiving extracorporeal therapy. And I think that overall, that tends to be the most common application. Of course, one always wonders if the timing of initiation of hemoabsorption therapy, if you wait until renal failure, are you waiting too long? Franz, you have experience with COVID-19 as well, or no?
Well, we were a non-COVID hospital. We have to treat the other population. We would have liked to treat the patient with hemoabsorption therapy, but there was no patient at all. We have not
Sure.
so much patients in Austria.
Right. Good for you. So we're in a similar situation in Pittsburgh. We don't have that much COVID-19. I think the patients that we consider using it on, or using hemoabsorption therapy on, though, would be a small subset of patients who have evidence of significant extrapulmonary organ involvement. And I'm just wondering, I didn't see it in your slides, Asim, but did the patients who received hemoabsorption therapy, did they have a lot of extrapulmonary manifestations besides the kidney injury? And I'm thinking about GI tract or cardiovascular or neurologic complications, and are those features, consistent with high severity COVID-19 in your experience?
Thank you for question, Professor Kellum. We try to exclude patients with severe comorbidity. So we have two patients in the first group with hemabsorption with diabetes mellitus type 2, the middle severity, and all patients has no cold.
Thank you. I think I'm just looking at some of the other questions that people have entered, and this relates to something you said, Franz, about the selection of patients for this therapy. And you had mentioned that IL-6 was perhaps not a great indicator because patients could be, highly inflamed and have a lot of vasomotor paralysis despite having modest levels of IL-6. So do you have a recommendation about how to select patients for hemoabsorption and what to measure?
If you have vasopressors going through the 3 link and you will kill the patient with the vasopressors, you should establish this therapy because you can get rid of these vasopressors, epinephrine, vasopressin, and so on, within about 24 to 36 hours in the most of the patients. I would establish it very, very early in this group of patients.
So you're basing it pretty much on the clinical phenotype in the sense of refractory shock is sort of an indicator for
Yes.
initiating presentation. Yeah. Do you tend to see in Austria? Austria is a wealthy country. Do you tend to see a lot of patients with refractory septic shock? Is that in some environments, patients don't have access to healthcare and they wait too long to come to hospital, and frequently they will have refractory shock on presentation. But we tend not to see it as much in wealthier countries. What's your sense of the frequency?
We see it quite often, I would say, because the patients do not come to the intensive care at the first station. They are on internal medicine, they are on some surgery, ward, and so on, and until they get in our department, that may take quite a long time. And there are, I think, the half of the patients we treat have severe vasoplegia and need a lot of vasopressors, and we would get rid of these vasopressors.
Interesting. Okay. All right. Very good. I think it also, relates to the COVID-19 situation, right? Because there are some patients, we don't tend to see patients with as much cardiovascular instability with COVID-19. So shock is not as significant a problem as it is in bacterial sepsis. And so patient selection for hemoabsorption in COVID-19, what are you using to select patients? Are you measuring cytokines, or are you just measuring those after they're enrolled in your research? What are you using clinically to select patients for hemoabsorption?
So we use, at first we use indications as for sepsis, like increasing levels of PCT. Then we start to use interleukin-6, but sometimes clinics and clinical symptoms, severity of diseases, and level of interleukin-6 are different and not correlated. That's why I think we should make some maybe statistical model with logit regression, maybe to try analyze all symptoms and analysis levels, how to divide patients into groups, because sometimes very young patients, about 30, had a very short time from onset of COVID till death. So that's why I think I saw the one investigation, Iranian investigation, and they suggested to start cytokine absorption in 50% and upper of lung injury, including saturation lower than 90, and that's why we need more carefully to find another criteria to start cytokine absorption.
Yeah.
Not and also acute kidney injury and CRT. In COVID patients, we shouldn't wait the third stage. I think we should start the second, maybe the first stage, taking into consideration the comorbidity phone.
Understood. Yeah, it's obviously one of the biggest challenges amongst the field of extracorporeal therapy, right? So we don't really know precisely when to initiate renal replacement therapy. We don't know precisely when to initiate extracorporeal membrane oxygenation. We don't know precisely when to initiate hemoabsorption. And of course, for all of these things, if we initiate patients very early, we have a better chance of having a positive effect. But at the same time, we're going to have to accept the fact that some patients that we initiate may not have ultimately recovered, may have recovered on their own and may not require it. So there's a little bit of a back and forth regarding patient selection. So I think for that, the safety considerations then come to the forefront. And so, Franz, you mentioned this a little bit in your presentation, but what safety concerns do you have regarding hemoabsorption?
The first is the bleeding. When we lose too much platelets, but we never saw a bleeding even with platelets around 10,000. This is one concern. The second concern is that we have uncontrolled drug removal that we do not want concerning antibiotics, concerning other drugs. We do not make therapeutic drug monitoring in our hospital. I think nearly nobody makes it in the surrounding, and therefore we can only go to a higher dose of the antibiotics.
And are you also potentially dosing some medication around the hemoabsorption, or are you just running hemoabsorption 24 hours at a time? How many hours a day or is the hemoabsorption being run?
We run 3 cartridges. The first we change about after 10 hours because we have seen that regarding bilirubin, the cartridge is full after about 14 hours. Then the cartridge is saturated, and you cannot get more bilirubin out of the patient. And then we change about after 16 hours, and the last runs 24 hours.
Okay. Yeah, based on membranes or on filter saturation, I suppose. All right, so that's an interesting protocol. I think for the use of hemoabsorption, if you're using it, for example, 8 hours at a time, and then you're taking a break and then using it again, you can dose many of your medications around the hemoabsorption. But if you're using it more continuously, as you are, then you're right. You're going to have to increase the dose. Awesome. What are your concerns regarding safety of the therapy? Have you discovered any adverse events that you're concerned about?
From hemoabsorption therapy, we hadn't had any adverse any adverse situation. We do a lot of renal replacement therapy, and the whole staff is very familiar to the modality, and therefore we choose our modality for renal replacement therapy. We can use citrate in a very low concentration. We can use our central venous lines like we have it, and there is no problem at all with additional hemoabsorption therapy. If you use heparin, you may get much more clotting, and people who do that, they have severe problems with the therapy.
Awesome. What's your experience?
As for me, I can tell about patients with sepsis before COVID pandemic. We use in patients with sepsis, septic shock, and with with liver, chronic liver failure. They had thrombocytopenia and coagulopathy. So we didn't use heparin, but I think when ICU doctors correct coagulopathy and after fresh frozen plasma infusion, we saw clotting of colon after the second hours of procedure duration. But usually we use ACT control every hours, and if patients has a good coagulation, we try to keep ACT about 220 seconds. For example, what about Alteca absorber? We try to keep ACT about 240 seconds. So I think we should also recommend to have a ACT meter apparatus for it's really help to protect extracorporeal circuit.
Any other adverse events that you've discovered with the therapy?
Also, I want to point hypertension because patients with vasopressors and hypertension also always react. We try to full circuit by helofusine, but it didn't help us, especially if patient has a low weight. It also show us high risk of hypertension.
Hypotension, low blood pressure.
Low blood pressure from the beginning of procedure. We lose some volume
because of the volume.
Yes, because of the volume.
Yeah, the dead space in the device is relatively small, but I suppose in a very small individual that might be significant. Franz, it seems as though your experience has been that you get reversal of hypotension though in these septic shock patients more often than not, right?
Yes. Our problem is the high amount of vasopressors that you need to get blood pressure, and we do not have problems with hypertension. We even have problems with hypotensions in the beginning, but we see that the blood pressure comes up after 12 hours to 16 hours, and you need a lower amount of vasopressors then. We would not use heparin because for anticoagulation, because every time when you use heparin, you will get bleedings, and the citrate anticoagulation is controlled by post-filter calcium, and this is very easily done with the blood gas machines. This is very comfortable. We do not have a single. We do not have a single bleeding even in renal replacement therapy.
Understood. We have about a minute left, Franz, and I'd like you to address one of the questions regarding supportive liver failure. So if you can give us your 45-second comment on that.
We use it in liver failure if the bilirubin was about over 15 to 25, and we could reduce bilirubin very, very potently. But if you stop the therapy and you have not solved the problem, the bilirubin will go up again.
Very good, thank you. So we have about 15 seconds left, so I just want to thank our speakers And I want to thank the audience for participating in this discussion. And please enjoy the rest of your day. Take care. Bye-bye.